Morning. My name is Deborah Ulster. I'm from the Office of Behavioral and Social Sciences Research, and I'd like to welcome you all to our first talk of the season, as it were. I'm really pleased to be able to introduce our speaker today, Dr. George Loewenstein. He's the Herbert A. Simon Professor of Economics and Psychology at Carnegie Mellon University. He got his PhD from Yale. And has held academic positions at many prestigious places, the University of Chicago, Carnegie Mellon, fellowships at the Center for Advanced Study in the Behavioral Sciences, the Institute for Advanced Study at Princeton, the Russell Sage Foundation, and the Institute for Advanced Study in Berlin. And he has many distinguished honors, but I don't want to take away from his time because we really want to hear what he has to say, not what I have to say. So with that, I will turn over the microphone. The title of his talk is Behavioral Economics, Classical Economics, Public Policy, Politics, and Health. Please help me welcome Dr. Loewenstein.
Dr. Ulster invited me a long time ago and asked me to come up with a title, and so I tried to come up with a title that was sufficiently expansive so I could give any talk that I wanted to give when the time came. But hopefully the talk itself is a lot shorter than the title, because I really am hoping that we'll have time for discussion. This is research. I'm going to be talking about research with Kevin Volpe and a number of other colleagues who I'm going to be acknowledging as we go along at Carnegie Mellon, Penn, Harvard, other places. It's sort of loosely, a better title might be Redesigning Employee Health Incentives, Lessons from Behavioral Economics. My talk is loosely based on a forthcoming paper that we have. Okay, so this is not going to be new to anybody, but healthcare costs in this country are out of control, much higher than in any other country in the world per capita. If you do a regression where you look at income, where you look at health expenditures as a function of income, you see there's a really, really nice line. These are different countries with one outlier, and that is the United States. In fact, this outlier isn't even in the right place. It would have to be off the graph, but there's no room on the graph for the United States. There's a lot of potentially effective remedies for dealing with the problem of out-of-control healthcare costs. We could, for example, cease reimbursement of high-cost tests and procedures that are of questionable value, and that Britain has, of course, been a leader in this area with their NICE panel. We could eliminate easily avoidable conflicts of interest, which is another research of interest of mine. We could change the compensation of doctors, minimizing fee-for-service arrangements. Probably all of these would be potentially, if they were implemented in the right way, could be effective remedies for the out-of-control healthcare costs. None of these are part of the healthcare reform bill, unfortunately. There's one other possible avenue of cost cutting other than these ones that I just mentioned, and that is to change individuals' health behaviors. If we can only make people healthier, then we won't have to give them health care. And of course, and there is some logic to that. It's better to prevent a case of lung cancer than to treat it. So there is some logic to trying to change healthcare behaviors. And healthcare behaviors are undeniably disastrous. We, of course, have an obesity epidemic in this country. The obesity rate went from 13% to 31% from 1960 to 2000. Over half of the population now is overweight. It's been estimated that lifestyle diseases caused, for example, by tobacco, alcohol use, and obesity account for about a third of premature deaths in this country. And we do have a variety of potentially beneficial treatments and medications to control these lifestyle diseases and also other types of diseases. However, the effectiveness of these medications and treatments is stymied by poor adherence. Here's one study by Jacovitis et al., which looked at the rate of statin adherence over time for different populations. And the bottom line is people with acute coronary syndrome. And you can see that most people are, their adherence is dropping to about, for the average person, sorry, that would be the top line, not the bottom line. For an average person, adherence is dropping to 50% after less than a year. But even for people with acute coronary syndrome, only after about 2 years, only half of them are taking their statins. And you'd think that they would be highly motivated to take medications to avoid another heart attack, but they're not, strangely enough. Poor medication adherence is associated with higher rates of disease, death, increased healthcare costs. It's been estimated, one estimate is $100 billion per year, the cost of poor medication adherence. And it's generally the case that even very efficacious medications don't have an impact if people don't take them, obviously. Okay, the healthcare reform bill includes several provisions aimed at changing health behaviors. One of them is calorie posting. It mandates calorie posting at chain restaurants nationally. I've actually done a lot of research on this, and many other people have. And with the exception of one study that looked at people at Starbucks, which is not exactly the target of the legislation, with the exception of that one study, all of these studies have reached similar conclusions, which is that calorie posting doesn't seem to have any impact on eating behavior. Another approach of the healthcare reform bill is value-based insurance design. Section 2713 of the Affordable Care Act mandates that recommended services be covered without cost sharing. And once again, this sounds like a good idea. It is the case when you raise the copays on services that fewer people get them. However, all of the research that I've seen, and quite a bit of research, has not found generally that when you lower copays on medication, that more people tend to take them. So VBID, as it's called, does not actually seem to be a very effective way of getting people to take their medications. And that actually kind of relates to the general theme of my talk. And finally, the healthcare reform bill introduces provisions to condition health premiums on health behaviors. The so-called Safeway Amendment allows for up to 50% premium adjustments based on outcome-based assessments, smoking, BMI, blood pressure, cholesterol. And it's called the Safeway Amendment because it's based on Safeway's claims of flat costs in the past 5 years from tying premiums to biometric measures. However, there's been a lot of challenges to Safeway's claims. There's a Washington Post article. The headline is, "Misleading Claims About Safeway Wellness Incentives Shape Healthcare Bill." If you look carefully, their flat costs actually preceded the intervention that they introduced. So it really doesn't make any sense for them to claim that their intervention caused the flat costs. And in fact, beyond this evidence from so-called evidence from Safeway, there's amazingly little other evidence that this approach is effective. This approach being the approach of conditioning premiums on these different health measures, behavior and other types of measures. So the main purpose of health insurance is to redistribute burdens of illness between healthy people and sick people, kind of to share the costs of poor health, right? The Safeway Amendment is going to undermine this purpose, and it's going to increase premiums for low-income families and minorities who tend to have worse health behaviors, and it's going to lower premiums for healthy people, and that is regressive. And the stated purpose of the Safeway Amendment is to promote healthier behaviors and reduce costs, but the worst possible outcome will be if the Safeway Amendment introduces greater regressivity. It causes poor, unhealthy people who tend to, poor people tend to be more likely to smoke, have higher BMIs and so on, causes the exact people who can't afford the premiums to raise their premiums, and at the same time, it has little impact on behavior. That's the worst possible outcome. So what can behavioral economics contribute to this? Well, the train has left the station on the Safeway Amendment as part of healthcare reform, so we can't do anything about that. But a major implication of behavioral economics is that a dollar does not equal a dollar does not equal a dollar. What I mean by that is there are ways of delivering incentives to people where you might as well just burn the money. It's going to have no impact on people. And there are other ways of taking exactly the same incentives and making them much more effective. And how premium conditioning is implemented is going to determine whether or not it changes behavior. That is, whether or not we, in addition to the regressivity of the Safeway Amendment, we also get some benefits from it. So let me change gears for a moment and to leave the domain of healthcare behavior and illustrate my point with two different programs. These were designed to stimulate savings behavior among low-income people. Again, these are programs not in the domain of health, but I think they illustrate the general theme that I'm trying to convey. So the problem is we have all sorts of tax-protected savings in this country, like IRAs, 401ks, and so on. But these only give you benefits. They give you benefits to the degree that you're in a high tax bracket because they give you tax deductions. That's only helpful to you if you're in a high income tax bracket. So poor people don't get the same benefits for saving as rich people. And so there have been efforts to try to come up with programs to give poor people the same benefits that rich people enjoy. And two different programs were tested by academic researchers collaborating with H&R Block. The first one was what was called the Savers Credit, which was enacted in 2001. In this program, there was a federal income tax reduction of up to 50% of funds contributed to an IRA. So if a low-income individual contributed, let's say, $100 to the IRA, their taxes would be cut by $50. So effectively, it's effectively a 100% match. You put in $100 and you put in $50, effectively you get $100. It's a 100% match on your savings. Solution 2 was a savings match, and this was tested a few years later. And in this solution, clients preparing tax returns at H&R Block offices were assigned to one of 3 match rates for IRA contributions. There was a control group that got no match, a 20% match group, and so every $100 they put in, H&R Block, as it appeared to them anyway, put in an extra $20. And there was also a 50% match where there was an extra, for $100 savings, it would be extra $50. So you can see solution 2 is considerably less generous than solution 1. But let's take a look at the results. The Savers credit, the take-up rate was 3%, and among those 3%, the average contribution to the IRA was $587. This is with a 100% effective match. If you look at the match experiment, the control was 3% take-up rate. That is, they didn't give them anything, but 3% contributed to the IRA then and there, and they contributed an average of $765. Now, these are 2 different population groups and 2 different years, so you can't strictly compare the 2, but it doesn't look like the Savers credit had much of an impact. However, if you look at the 20% match, 8%, there's an 8% take-up rate, $1,100 conditional average contribution, and with the 50% match, it was a 14% take-up rate. So the point is that these 2 programs, the more generous program had seemingly no impact on behavior. The less generous program had quite a big impact on behavior, and the point is that really matters how you implement incentives. Why the difference in the opposite direction from the objective incentives? Probably it has something to do, this is pure conjecture, the Savers credit, the benefit was integrated with the income tax, and so it was not very salient to them. And second, the reduction, poor people don't pay a lot of income tax, but still for them it's a large amount, and the reduction in the amount that they paid was not very large compared to the amount of tax that they were paying. So the reduction was kind of amorphous to them. The match, in contrast, was separated and more, as a result, more salient. And with the match, it feels like you're getting a gift, and you're going to forego, you're going to lose the gift if you don't put some money aside. It's like someone's ready to give you $20, and you're going to give up the $20 if you don't put in your own $100. And so the second one is just psychologically very different, even though from an economic perspective it's less generous. Now, most health programs ignore the most basic lessons of economics. Here's a program that's offered by an insurance company. It's a fitness program. It's designed to get people to exercise. They can get up to $150 back for joining and using the gym. It's got a picture of attractive people. Among other, that part is probably good. That probably does help people to exercise. Among other things, regular physical activity can help you to reduce cholesterol. And, okay, it tells you why you should do it. And complete 120 workouts in 365 days, and you'll be eligible for a reimbursement of up to $150. Well, if you wanted to burn $150, you couldn't come up with a better way of doing it. This has a lot of design flaws. The rewards are once a year. There's a single high threshold. How many people are going to go to the gym 120 times? Probably only people who are already going to the gym 120 times. So this program is going to spend $150 on a bunch of people who were going to exercise anyway, and probably isn't going to get anybody who wasn't exercising to exercise. If you look at the typical healthcare plan, this is just like the data you get. You have to make a decision between these two plans. If you look at the typical healthcare plan, I'm not going to actually go through the details, but all of you know that typical healthcare plan is absolutely bewildering. Obviously, a lot of thought went into designing that plan. There's a lot of detail. The designers of the plan wanted to incentivize the subscribers to behave in very specific ways. But after actually way more than an hour of scrutiny by one person with a PhD in economics, obviously myself, I couldn't figure out what these plans are all about. In fact, I couldn't figure out really what the fundamental difference between the two plans was, or which plan I would personally choose. And if you can't understand how the plans work, how could they possibly incentivize you to behave in any way? So our approach, Kevin and mine and our collaborators, our general approach is to use decision errors to help people. So behavioral economics is very concerned with the kind of common decision errors that people make in day-to-day life. And the approach that we've been taking is to try to use the same errors that usually hurt people to instead help them. And for example, people tend to be very short-sighted, right? They're very oriented towards immediate cost and benefits. That's usually a bad thing. That's part of the reason why we don't save money. It's part of the reason why we gain weight, because the immediate food is very attractive to us. So, but it's possible to play on present bias preferences and incentive programs by making rewards for beneficial behavior very frequent and immediate. Steve Higgins and his colleagues who do research with drug addicts, they do programs with drug addicts, have had remarkable success. So you take an addict, the addict is like living on the street, they've lost their family, they're unemployed and so on. They have every motive to kick their habit. They don't kick their habit. But you give them small coupons good for really small rewards, like at stores, and all of a sudden it has a huge impact on behavior, whereas the much, much larger impact, motivation to kick the habit and get your life together doesn't seem to work. Framing and segregating rewards, I've already talked about that. with the tail of the two tax-protected savings programs. But a $100 reward is much more likely to be effective than a $100 discount on a health premium for many reasons. One, the $100 reward is kind of separated, and two, it's not buried in a much larger amount. People tend to overweight small probabilities, and so in a lot of our research, as you'll see, we often give people lottery rewards. People love lotteries in part because they exaggerate the likelihood of winning. So if people love lotteries, let's give them lottery rewards, and so on. So let me just give you one example. I'm not going to go through the psychology in this example in great detail, but I'm just going to use it to illustrate that in healthcare, very much like in savings for low-income families, in healthcare, how you implement a program makes a big difference. This is a study with Emily Hazley, a former graduate student, Kevin Volp, Tom Pelethy, and in it, a healthcare company headquartered in Pittsburgh told us that they were having trouble getting their employees to complete health risk assessments, and asked for our help. And they were paying $25 to employees who completed an HRA, and they were willing to go up to $50. So what we did was we gave everyone the original $25 cash incentive for completing the HRA, and there was a control group that got no extra reward, and then there was a direct payment group where we gave them a $25 grocery gift certificate. So effectively we doubled, everyone shops for groceries, effectively we doubled their monetary reward. And then we introduced a lottery condition, which is one of these kind of behavioral economics interventions that plays on biases. We divided employees into groups of 4 to 8. Each week, one group from each work site was randomly selected, and individuals in the group, in the selected group who had completed an HRA, won $100. And individuals in the group who hadn't completed the HRA knew that the other people in the group had completed HRAs and received $100, and that they'd missed out on the $100. And we increased the prize to $125 if 80% of the work group had completed the HRA. You can see we're playing on group pressure, we're playing on regret, and we're playing on people's love of lotteries and so on. Really an important feature of this is that the lottery intervention, the expected value of it was $25. So we can either give people $25 or we can give people $25 in a different way. And here are the results. Here's the control condition that got $25. This is the condition where they got $25 and the $25 grocery certificate if they completed the HRA, and the lottery condition was much higher. Actually, the lottery, this is a very, very conservative estimate of the impact of the lottery condition. A bunch of people couldn't actually sign up for the lottery for complex reasons, and this is based on intention to treat. And another feature of this is we looked at income. We looked at the impact of these interventions as a function of income. We just did a median split on the population and looked at low-income people who tended to be like support staff and higher income people. And if you look at the impact among the high-income people, the lottery was a little bit more effective, but not that much more effective. But the lottery was especially effective among the low-income groups. And very often, as we discussed earlier, very often low-income people are exactly the people you want to target with these types of interventions because they tend to have poorer health and poorer health behaviors. Another study we did now a ways back, this is applying behavioral economics to weight loss. Again, it exploited decision errors to help people. This is in the first study we ran on weight loss, it was a 3-condition randomized controlled trial. There were 3 conditions: a control condition where they went to a dietitian for an hour-long session, and there were 2 incentive conditions, a lottery condition and a deposit contract condition. At the start, subjects were obese, they were all veterans. Almost all of them were male. They were, I told you about they all received the 1-hour consultation. They were given the goal, everyone was given the goal of losing 4 pounds per month for 4 months. At the end of each month, they came into the lab and they were weighed on our clinic scale. And in the 2 incentive conditions, they were given a scale to take home. In the incentive conditions, they were asked to phone in their daily weight, and we sent them a daily text message. So we're trying to give them we're trying to give them frequent feedback consistent with present bias. And they receive their, and they also, the text message, if they get rewards, it tells them how much they've received. At the end of the month, when they come into the clinic, they actually get the money. So in effect, it's almost like we're paying them twice. Every day we're telling them how much money they've earned, so we're giving them kind of a symbolic reward, and at the end of the month, they're getting the actual reward. So it's almost like the money is doing double duty. So here's somebody, a veteran who starts out at 250 pounds, and their goal is to lose 16 pounds in 16 weeks in this program. And if they stay under this line, then they get the rewards. Suppose that they don't stay under the line. What do we do? Well, one thing we could have done is we could have just shifted the line out here, parallel line like this, and they can just start again. We didn't want to do that because that would provide them with that would kind of give them an incentive to procrastinate. Like this month I won't lose weight, and then next month I'm going to start the program. Another thing we could have done was just kept this line where it is, but then take somebody who's here, after a month they haven't lost any weight, and now they have to lose 4 pounds to get under the green line. They'd probably give up at a certain point. And so this was kind of a compromise where there's a fresh start trajectory, but it's steeper. They have to lose more. They have to lose more weight each. They have to lose more weight each day to stay under the line. This is like typical kind of design consideration that goes into these types of programs. Some of it is science. A lot of it is just like brainstorming and trying to solve problems. Okay, in the lottery incentive, the subject chose a 2-digit number, for example, 27, and every day we drew a 2-digit number. If the first 2 digits matched, like we drew a 25, or if the second digits matched, we drew a 57, then they won $10. If both digits match, so it's almost a 1 in 5 chance of winning $10, $2 expected value. If both digits match, they win $100, and it's a 1 in 100 chance of winning $100. So the total expected value of the gamble is $3 a day. But they only got their money, they only got their winnings if they called in that day and if they called in their weight and reported their weight being below the goal. And by the way, if they came in at the end of the month and their weight wasn't what it was reported to be, then they didn't get any of their winnings, of course. And so every day we transmitted a text message to the subject telling them whether they won or whether they would have won if they had met their goal. So like today, you won $10 today, but too bad you didn't call in your weight, or unfortunately you were above your weight loss trajectory, so you don't get the $10. So we're playing on regret. So I've already said the lottery incentive condition plays on regret, and it also plays on nonlinear probability weighting on people's love of lotteries. People love lotteries, so let's give them lottery rewards. Okay, in the deposit contract incentive condition, subjects were allowed to, at the beginning of each month, they could put down their own money from a penny a day to $3 a day toward weight loss, and we matched each of their deposits 1-to-1, plus we gave them a $3 daily payment. Of course, all of these rewards are contingent on them staying below their weight loss trajectory. If they go above the weight loss trajectory, then they don't get our money, and they lose their own money. That's why it's called a deposit contract. And the deposit contract condition plays on over-optimism. People are notoriously over-optimistic about their ability to exercise all types of self-control, including losing weight. And so people think, oh, I am going to lose 4 pounds this month. And based on that, they're ready to put down a big deposit. And then, due to a phenomenon that behavioral economists call loss aversion, people hate losing money. They don't want to lose the money that they put down. And so it becomes a kind of self-fulfilling prophecy, self-fulfilling over-optimism. Here are the results. This is the total weight loss, again, intention to treat by condition. And you can see that the lottery and the deposit contract were both very effective. And we asked them, of course, a bunch of questions, and including did they change their diet? Did they change their exercise? We didn't see any relationship between losing weight and diet, but we saw a big relationship between losing weight and exercise. Now, this is, I've told you the good news about the study. The bad news is that we followed them up 7 months later, and after 7 months, not only had they not continued to lose weight, but they gained back most of the weight that they lost. So based on the fact that they regained their weight, we wondered, like, can a similar but less expensive approach be applied to extended weight loss? Again, deposit contracts, no longer a fixed payment of $3, just a match, a pure match. And once again, we found that the program was very successful in getting people to lose weight and keep the weight off for 8 months instead of 4 months. But once again, really bad news. When we followed them up at 17 months, they had regained pretty much all of the weight that they had lost. Another program that we did, and I'm going to end in 7 minutes because I want to have an extended discussion. Another program that we did involved incentives for medication adherence using daily lotteries. This is done with warfarin. It's an anti-stroke medication with unambiguous benefits, but non-adherence rates are high. And warfarin's a very, a lot of you are probably doctors, so I shouldn't even be telling you this, but warfarin's a very dangerous drug. If you take too much of it, you can bleed internally, die from internal bleeding. And so a lot of doctors are afraid of prescribing warfarin to their patients because, even though it's very, very beneficial, because it's so dangerous, because adherence is so poor. So we designed an intervention to get people to take their warfarin and, the right amount of time, not too much, not too little. And again, it's exactly the same lottery that I told you about before. And again, we play on regret. We tell them about their winnings, and we tell them if they won but they didn't take their warfarin, then we say, oh, too bad, you won the lottery, but because you didn't take your warfarin, you don't get paid. Now, hopefully, if you haven't already seen this, you're wondering, how did we know whether they took their warfarin? And the answer is with this, by now, a very old-fashioned piece of technology, because the technology is developing incredibly quickly now. But this is an old piece of technology called a Remedies monitor, which communicates by telephone. It communicates with the patients, and also it's got these little pill compartments, and when the patient opens up the compartment, it sends us a message. So we know at least, we don't know whether they took their warfarin, but we know whether they opened the compartment. And most people who are taking warfarin are pretty motivated to take it. I mean, if you've had a stroke, about a 15% chance that you're going to have another stroke in the next year if you don't treat it. You can reduce that to about 3% if you take your warfarin. Most people don't want to have a stroke, and so on. So rates of non-adherence to warfarin were reduced with these lottery-based incentives quite dramatically. These are the INR rates, people being properly coagulated. You can see that they were not properly coagulated before the treatment, much, much better during the treatment. But once again, same message as for the weight loss. As soon as we removed the incentives, they went back to their old poor rates of adherence. So, in my opinion, all of this, yes?
Was compliance validated with blood tests?
This is, sorry, these are the blood tests.
Okay.
Yeah, I should have clarified this. So these are the data from the Remedies monitor, and these are the data from the blood tests. So in my opinion, a really big issue for these types of interventions is habit formation. For something like the HRA completion, a one-shot thing or a flu shot or something like that, these types of interventions seem to work really, really well. They also work pretty well for more difficult behaviors like weight loss and medication adherence, but there's a big problem that as soon as the incentive, for ongoing behavior change, as soon as the incentives are removed, so far we haven't been able to develop habits. We're doing a bunch of research to try to fix that problem. So in sum, premium adjustments for health behavior are coming. They're part of the healthcare reform. Their pitfalls are clear. That is, they're going to introduce greater regressivity. The poor people who can least afford to pay more for healthcare are going to be paying more for healthcare. And it would be a tragedy if they don't also have their intended effect, which is to change behavior. Interventions based on behavioral economics have been successful in changing behavior, and these ideas can be used to ensure that the incentives for healthy behavior introduced by healthcare reform will actually have their intended impact. Yes. Yes.
Great talk, and really very fascinating work on human behavior. I'd like to go back to the first slide that showed the U.S. as an outlier. The implications of your talk, and I suspect that maybe this is unintended, is that that gap could be modified by individual behaviors and healthcare utilization. The one thing that you didn't address, even in your outline of potential ways to moderate that gap, is the impact of the business model in the U.S. for healthcare.
Mm-hmm.
So I'm willing to bet that virtually everyone's retirement plan includes ownership of stock in healthcare companies that are profit-oriented. There's pressure from the stockholders to be profitable. There's payment to executives. I think there's maybe the concept of a fourth-party payer. We're familiar with the third-party payer, but maybe there's a fourth-party payer, namely now you have these healthcare conglomerates that are skimming off profits that at one time was not the case, even in the United States. And I've heard this discussed a number of times, but I've never had anyone who really was knowledgeable in terms of being able to answer to what extent that profit aspect,
Yes.
which is probably unique in the United States. I doubt that there's anywhere else in the world that you have as much of a business model in healthcare as you have.
Yeah, you have yeah, there are a variety of different models in different countries. But
And I'm just wondering how
yes.
much that
Yeah.
profit aspect contributes
Yeah.
to this.
Well, your question really worries me because you began with something that's exactly the opposite of the point I was trying to make. In my opinion, all of the really effective ways of cutting costs are exactly deal with the business model. They deal with the way that we administer healthcare in this country. And I don't think that the answer to the healthcare cost problem is to change behavior. All I was saying was that, of course, changing health behavior is a valid goal. It could reduce costs. All I'm saying is that the Safeway Amendment is going to have negative consequences that many people would view as negative. It's going to increase regressivity, and it's quite likely, the way it's going to, very likely going to be introduced, that it's not going to have any compensating benefits, and that we need to think carefully about how the incentives are introduced so that it does have compensating benefits. But I very much think that changing healthcare behaviors is not the way to reduce healthcare costs in this country, and that was the point of this slide. I mean, I think it will help, but there are other, that's not where the action is, really.
That's kind of what I suspect, but the one bullet that is missing from there, unless it's kind of reading between the lines, is the actual profit model of large conglomerates
Yes.
with
Yes.
set standards for, 10 minutes per patient.
Right.
And so on.
I would say I was intending these to cover exactly the point that you're making. So I do think a difference in business model would affect all of these 3 points. Michael.
I'm curious what your practical experience has been proposing interventions like this in environments that are principally filled with non-economists. So I'm an economist too, and of course I'm all over this stuff. I mean, this is totally the way I think about it too. My own more limited experience has been going into clinical settings, including academic settings, including in Pittsburgh.
Yes.
And proposing to clinicians and non-economist health services researchers interventions like this.
Yes.
That people, in my limited experience, often kind of blanch and have a kind of a reflexively ethical response of, ooh, but that would be coercive. And I'm curious, do you have that experience as well? And kind of.
Well, when I told my mother asked me about what the research I do, and when I told her about it, her reaction was, "You're paying people for doing what they should be doing on their own?" Like she was kind of horrified, and I have to admit that a part of me shares the reservations, and I don't think we don't want a Walden II society where we're paying people for doing the things that are good for them, and so I think first there are a lot of incentives built into inevitably there are going to be incentives built into any plan, and if they are built in, we might as well implement them in a way that they're going to help. I don't think we want to move to a society where we're incentivizing people to do all sorts of different things. We don't even know what's going to, forget about the ethics, we don't even know whether it's going to be effective. All of these experiments focus on one behavior. We have no idea what would happen if we incentivized multiple behaviors. So I share those psychologists or clinicians' reservations and my mother's reservations. And on the other hand, take something like, again, Higgins, a psychologist who does a lot of this work, but he's done a bunch of work targeting pregnant teenagers who smoke and incentivizing them to not smoke. Now that, to me, seems pretty non-controversial. It's very, very effective. Other types of approaches haven't been proven to be effective. So I think targeted incentives, targeted to the right people in the right circumstances, can be desirable and beneficial. But I share these ethical qualms that you're mentioning. Richard?
Yeah, George. The big question is really the overall cost effectiveness of your approach, realizing that NIH is supposed to help, but we also want to look at cost effectiveness. It's expensive paying people.
Yes.
And the question is, what is the cost effectiveness? The other alternative, if you is the Bateson, Madrian, Choi use of the pulse, which was enormously effective in increasing especially the 401ks, where people were leaving matches
Yes.
on the table,
Right.
on the floor. They could have matched, put in,
Yes.
pulled out some stuff out their match and had 10, 15% profit in a day.
Right. Certainly there's a lot of low-hanging fruit when it comes to defaults and other kinds of nudges that don't cost anything. And we should go as far as we can with those, in my opinion. But take something like warfarin adherence. I'm not exactly sure how you default somebody to take the correct amount of warfarin. And so those are situations where you might need other types of interventions, and possibly incentive-based interventions. In our research, we have attempted to, take the warfarin case, how do we choose $3 expected value a day? We did a pretty casual estimation of how much would it save an insurance company to get somebody who was non-adherent to warfarin to become adherent. So and it was, so the $3 a day is a very conservative estimate. Now, some of these other, take the healthcare reform, that doesn't really cost anything. That's simply getting people with poor health behaviors to pay more and people with good health behaviors to pay less. So that we don't really have to worry about the cost effectiveness there. All we really have to worry about is effectiveness.
So where would you see the field going in 3 to 5 years?
The whole field?
Behavioral economic approach to nudging people with.
I mean, I think there's going to continue to be research on use of defaults and nudges. I think we still have further to go. We just did a program, a collaboration with CVS, where we got people to using defaults. We actually not using defaults, but using kind of forced choice, forcing people to make a choice. We got a huge increase in people doing mail order over going to the pharmacy. So I think there still is a big scope for that. But I think the big short-term issue is the issue that I raised. How can we inculcate habits? Because we don't want to be introducing long-term incentives for too many behaviors. Yes?
Yeah, so with respect to the changing of habits, one of the things that, I'm particularly working in intervention, and one of the things that we see there is that the only way that you really can change behaviors and health behaviors is basically to get a group behavior. Now, in one of your studies, you showed that you, in the insurance part, you made it such that your incentives became larger if you actually got a group behavior. Did you in that group also see that the behavior lasted longer?
Well, that was a one-shot. I'm completing the HRAs. But I'm really glad that you raised that, because it actually gives me a better answer to Dr. Sussman's question. And that is, so far, we've mainly been doing kind of individualistic rewards. But I completely agree with you that a really important new area for research, both with incentives and without incentives, is kind of group rewards, group pressure, and so on. We just did a intervention, hopefully it's about to get accepted for publication, with diabetes patients, where we compared monetary reward program to a peer mentor program. And the peer mentor program, so we took somebody who had out of control diabetes, and they had gotten it under control, and they were the mentor, and they worked with somebody who didn't have it under control. And the peer mentor program was extremely effective and more effective than the incentive program. So I completely agree with you that groups, dyads, and so on is a really important new area with and without incentives. And that's another area we should be going into in the future. Yes?
Why do you think that business interests that have at least the potential to capture financial benefits from improvements in insurance companies, employers by their own, why have they not been more out fronting, developing and implementing these kinds of incentive strategies? And do you think there are particular obstacles to their uptake where behavioral economics might inform their behavior?
I mean, the insurance companies are enormously interested in this, and we're working with a range of insurance companies to test interventions like this with their populations. Also, we're doing this work with CVS, pharmacy benefits manager. So there's enormous commercial interest. Now, maybe there's not as much interest as there could be, and the reason for that would be that in today's fragmented healthcare market, and this goes back to your point, where people are changing jobs and they're changing insurers all the time, an insurer who spends money to change an employee's health behavior is very likely to not actually capture the gains from the improvement in health. And so that's another big disadvantage of the way that we do things now. But there is a huge interest among insurers, despite that fact, in these types of interventions. In the back.
A lot of the provisions of the ACA were designed to affect the behavior of clinicians, and they're controlling a lot of most of the incentives that are offered are really quite few. We'll give you more money if you do this, you get doctor reimbursement if you do that. Are there any experiments going, or are you doing any planning for being more intelligent about the way to incentivize providers? They're the problem.
We are. We're doing a lot of research on that, and that is more in progress. So that's why I didn't talk about it. But I agree, it's a very, very important area, and the a specific one focus in that research is on the impact of limiting conflicts of interest. What's the impact of reducing conflicts of interest on physician behavior? But also we're looking at the impact of, like for example, in diabetes management, we're comparing the impact of incentivizing patients, incentivizing physicians, incentivizing both or neither. So yeah, I completely agree with you. That's a really another, you're all giving me good responses to Dr. Sussman's question. That's another really important area of future research. Yes? Oh, sure.
The takeaway I'm getting from this is basically that at the moment you have a way to deal on a short-term level with improvement, but we don't know whether that particular way will work in a long fact, whether that would wear off over a long period of time. And we know for a fact that it doesn't generalize past a particular time that is given. So how does this represent the real weapon in
Well, okay. I mean, I'm trying to be very direct with you about the the good things and the bad things. Like, but let me nevertheless. First, there's a lot of things in healthcare that are one shot, like vaccinations and completing HRAs and so on, and these approaches are very effective for those. Second, all of our interventions have been persistently effective as long as we've kept the incentives going. And some of them are quite cost effective. So you could say, fine, where it's really important, let's just keep the incentives going as long as we want to change the behavior. You're right. The weak point is that we don't yet know how to develop programs where when we remove the incentives, the behavior persists. No, but we have the 4 months versus 8 months of weight loss, and also I think these incentives are really designed to have a persistent effect because they involve a lot of interaction between the clinician and the patient. The patient keeps putting the money down, or keeps getting these messages. You won $100 today, but you don't get it, and so on. And those are pretty compelling messages. And that's right. I mean, we don't have evidence beyond 8 months, but we're pretty optimistic on that point. Yes. Yes. Well, there is some research going on. I'm not at all an expert on research funding and things like that, but I think there is a lot of research going on in Medicare, Medicaid, trying to test trying to do field studies to test the impact of these types of interventions. And most of these studies that I'm showing you are kind of they're field studies, you know, real people and real situations. There are some methods that we can employ, you know, kind of crude interrupted time series to see if these measures have an impact. But so many things are going to be changing at the same time that you're right. We're not going to really know exactly if we get changes in behaviors, we're not going to know exactly what drives them. But let me say that I do think that a lot of the pieces of the Healthcare Reform Act are not evidence-based. So the calorie posting, like maybe people, perhaps you could argue, people deserve to have the information when they make food choices. They just deserve, it's an inherent good to have the information up there so you know how many calories you're taking in. But there's no evidence that that's going to have any positive impact on behavior. Same thing with VBID, same thing as my whole talk was about, same thing with the contingent insurance premiums. We have no evidence that that's actually going to have a beneficial effect. So pretty much all of the pieces of the Healthcare Reform Act that are designed to change health behaviors are not evidence-based. And you're right, we're not going to get data when the act is implemented. We're going to not get very usable information about what the impacts are. That's why we need to do more research of this type. Pitch, okay. And okay, let me.
I want to ask a question about the parents and the intensive community. Warfarin, we don't ever expect people to develop the habit of controlling their own sugar.
Yes.
And so it may be that, as you said, the research needs to be on identifying a sweet spot where it's cost effective to maintain the incentive permanently, but they also are sufficiently intermittent or whatever the psychological mechanisms are that make them effective for the long term.
Mm-hmm. That's right. And something I didn't really go into any detail about on the warfarin was we accidentally implemented the incentives wrong the first time we did it. It was $5. It was $5 a day instead of $3 a day, which is what we intended. And $5 a day was very effective. But then we started over again. We continued those people, but we started over again with a new group, $3 a day. And if anything, certainly there's no significant difference, but $3 a day was just as effective as $5. What if we did $3 a day is what we think is almost certainly cost effective. But what if we went down?
Put up your next slide. The other way around.
Okay. When, if you look at the blood, if you look at the yeah, that's right. That's right. The $3, the $5 looks proportionately more successful, but this is a small study. I would not. But the point is, we don't really know how low we can go. $3 is already. So I completely agree with your question, of course. But $3 is probably already cost effective. But it might be that a program involving $1 a day would also be effective, and then it would be way more cost effective. Yes.
Almost like people combine what you've been doing with some of-the-future ideas about how to make people who are similarly motivated.
Right.
It might, I just kind of make me think of like a, a drug to control appetite. That works in a particular way, but you have to make the person, have to help the person in another way to develop internal motivation.
Mm-hmm. Right. I agree that would be a great direction to go, and we are doing some interventions to try to develop habits that do play on psychology, but not exactly what you are talking about. Back to you.
The amount of it seems to be the rest on what Kurt Lewis did at MIT years and years ago, an approach, the demonstrative approach of avoidance.
Mm-hmm.
I was wondering, have you ever looked at the issue of put in a deposit for bail, and if you fail, it goes to the group you hate most, whether it's
Yeah.
ACLU or Tea Party or Ku Klux Klan. That might have longer last. You may be able to sort of spread out the reward or the punishment and keep it in people's minds for much longer time. Have you looked at things like that?
We haven't. There's a website called stick.com, and they use that. They use that. On the other hand, but I think,
Successful has it been?
well, they don't have any data because it's just a commercial website. But they, I think those types of ideas might be very promising, but you would certainly want to combine them with some of the ideas in our work, like, for example, the daily deposit, things like that. I think some of these programs where you put a lot of money down and then you have a long-term goal are much less likely to be effective than the types of programs that we do where you get daily feedback, which is, I think, is really important.
I wouldn't underestimate the power of hate.
Perhaps, yeah. Yes.
Just getting back to the evidence based on calorie posting, there have been some experiments done showing that the really important aspect is providing contextual information on the daily calorie requirement. That just simply posting calories may or may not be effective for some groups, much like the labeling on food particularly nutritionally. But
Yeah.
if you have contextual information to say that typical calorie intake is about 2,000 calories a day, it does in fact change behavior.
We did the only study that I know of on this, and I've often heard that claim, but I think that we did the only study, anyway, we did the only study that I know of exactly on this. We went to New York City before they introduced calorie posting in fast food restaurants, and we collected meal receipts, and even during that time, we randomly assigned people to get no contextual information, to get this is how many calories you should eat per day, this is how many calories you should eat for lunch. It was lunch. So very, very targeted contextual information. We went back after calorie posting a month later, and we had the same three groups. And giving them the contextual information had no beneficial effect. Even the daily, you'd think, I mean, we expected that it would, because you're going in, you're seeing the calorie information, and you're seeing this is how many calories you should eat for lunch. So you can directly compare the two. Daily, it's much more difficult, but it had no impact.
Yeah, so I know of some other
Okay.
research on that. So maybe we
Okay, I'd like to
And
see
then
that.
In addition to just simply changing individual behavior, I think another, and by the way, the American reform healthcare, it does include that contextual.
That's right, which is,
But
yeah.
another focus is not only on individual behavior, but also on reinformulation for industry. So it's not just simply looking at
Oh, yeah.
individual behavior.
That's a great point. I think that I'm very pessimistic that if you take a person who goes into McDonald's before and after calorie posting, that they're going to order a different meal. Maybe some people will, but it's probably not the people who we care about. Yeah. And I'm a little bit more optimistic about the idea that maybe a few people will not go to McDonald's and maybe go to Subway or something like that.
Or that maybe
Yeah.
McDonald's or Subway or somebody may.
Well, and that's the third point. I think the biggest area where this might have a benefit is if McDonald's, it's kind of a telltale heart effect. McDonald's and Subway are worried, oh, the information's out there now, we have to change our menu. And generally, I've done a lot of research on disclosure, and the reading that I've done, disclosure of information, for example, disclosure of conflicts of interest. Most of the literature on disclosure shows that to the degree that disclosure has an effect, a benefit, and it often does have a benefit, it doesn't operate through the consumer. It operates through the retailer, the producer, and so on. And I think that's true here too. If calorie posting has a benefit, almost for sure the biggest benefit will be if it changes the offerings of the fast food restaurants. Yes. Yes.
Following that idea, a dollar means different things, but that symbolic value as well as monetary value. So if you offer me money, you're proving at some level that you care. And if you call me and tell me about whether I won the lottery or not, you're reminding me that, oh, gee, I haven't done my exercise today.
Mm-hmm.
And so I'm wondering whether the using money and thinking about money instead of as for commercial value
Yes.
might give you some ideas about why some of these changes don't stick, or how to do them maybe for less money, or
Right.
to get to the long-term impact.
I totally agree with you that it's not just about the money, and it's not only about the types of issues that I've discussed, but also it's about the symbolic value. And for example, who's giving you the money? If it's a health insurer, you might feel like they're just doing it for their benefit. It's not for me. But maybe if it's your employer, even if it's your employer giving it to you, if you have a good relationship with your employer, maybe you're going to feel like, oh, they're doing it for me. They're not just doing it to save money. Who knows? But the issue, once you start thinking about the symbolic significance, then things like who does the money come from could potentially make a big difference. And so I agree. That's something that we really need to think carefully about, like how people, not only the incentive value, but how people interpret, like what's the meaning of the money. Yes?
Sort of a related question. I'm thinking about how a lot of customer loyalty programs use points to obscure the value
Yes.
of what you're doing. I was wondering if you've done any work or doing any work thinking about how you can make that more cost-effective by giving points as opposed to dollar for dollar. Could be obscuring the value, how to get a more cost-effective intervention.
Yeah.
Offering points and how to done the research on that.
Giving people like thousands of points instead of, yeah.
Every time you
It's certainly,
you get 100 points.
yeah.
But then you sort of decrease your the expected value. The lottery is still $100, and maybe the lottery
Yeah.
is
Certainly a lot of retailers seem to believe that that is an effective strategy. I wonder whether its effectiveness might be lower now than it was when they started doing it, because I think a lot of people are kind of cynical about points from their own experience with, trying to redeem them. And yeah, we've actually, in a completely different line of research, we worked with a bank on loyalty programs, and the bank's customers were really frustrated by a program like that. We started sending them surprise gifts, and that had a huge impact on their happiness with the bank, their loyalty to the bank, and actually their deposits went up, whereas for the control group they went down. So I think that these kind of loyalty programs and points and things like that, people are kind of burnt out on them. But so there might have been a time when that would be a good idea, but I think it might, just based on intuition, it may have passed. You have to tell me when. Okay,
Probably soon. but
okay.
I have one.
Maybe. Yeah. Okay. Sure.
You alluded to, I guess, Higgins data who uses younger people, adolescents, but in general, how does this work in kids? Would it be more effective to use these incentives or less, or might it help them instill habits, or are they going to be no different from adults?
Probably. Well, first, of course, incentives are used a lot with kids, and there's some very interesting studies involving paying kids for schoolwork. Yeah, and it turns out that it's much better to pay the kid. You might have been listening to NPR. What's the economist's name? Roland Fryer at Harvard. He's been doing these programs. He finds that if you pay the kids for reading a book or for concrete behaviors, showing up at school, that's quite effective. If you pay them to get good grades, that has no impact at all. And so there are certainly incentives can be very effective with kids. With children, you might want to, if you don't know how to get good grades, then it's better to incentivize the behaviors. Adults might have a better idea, like we incentivize people to lose weight. We didn't incentivize people to exercise or cut down on eating because we figured adults know how to lose weight, and these things are difficult to measure. But my reading of the literature on incentives for kids is that it's confronting exactly the same issues of habit formation. But incentives certainly are very powerful for kids. I do think that there's been some work on crowding out of intrinsic motivation, that if you pay children to do things, they won't be motivated to do them on their own. My own view is that that is kind of a bit overblown, and that children, all of us, we love doing things that we're good at, and we hate doing things that we're bad at. And so if you can pay somebody to do something to the point where they become comfortable with it, where they gain mastery, that can be a huge effect. Very, very likely much more powerful effect than the crowding out of intrinsic motivation that's been shown in studies where everything else is held constant. Yes? Okay, maybe we should. I'll answer your question personally.
Okay, so
Okay.
Please join me in thanking George for a great talk.
Thank you.
I have a fairly trivial question about the warfarin study.
Yeah.
Did all